the situation. And this is the other side. So we're normally very hesitant. We're not very proactive in treating coronary disease when a patient has critical aortic stenosis and is for TAVI. But in this case, with a dominant right and chest pain as well in the history, we thought we should go ahead. So the plan was a quick PCI and do the TAVI in the same setting. And this was what happened at pre-dilatation. And this was what happened later with a 2.5 balloon, with a 3.0 balloon, with a 3.5 NC, and at 24 atmospheres, and with a cutting balloon or the equivalent. So no effect. And we're still waiting for TAVI. What would you do next? Steve, I'll let you give one answer and then I'll move on.
So for the coronary, I think you'd have to do atherectomy to get it to yield, and I probably would reschedule the TAVI.
Yeah, that's exactly what we thought. You know, you have to stop here and do a complex procedure in the context of severe aortic stenosis, and yeah, we'll come to that later. Okay, hold that thought. The problem, of course, is calcium. And calcium can be everywhere. It can be diffuse, focal, less than 180 degrees, circumferential, deep, superficial. In our case, there is no doubt it's one of these circumferential calcium cases. And of course, when the balloon didn't go up, our fellow said, see, I told you, it was on the CT, which admittedly it had been. So calcium is bad, because it leads to failure to cross, failure to deliver, failure to dilate, underexpansion of stents, undesirable results, and a lot of complications when you attempt to treat it. So just to get one question out of the way, why not just increase the pressure in the balloon until it pops? That's why. That's one of my earlier experiences. Got away with no complication, but a ruptured balloon is one problem. We have ruptured vessels as well. So what we usually employ are some specific devices. Currently, we've got the scoring and cutting balloons. We've got rotational atherectomy and orbital atherectomy. Recently, I can't talk to that because I haven't used that one. We've got traditional balloons and we've got OPN balloons, which we have blown up to 50 atmospheres with good result, but you can, of course, you know, never quite know what happens to the artery when you do that. And of course, we have Shockwave, and we'll talk about that at the end. So, as we saw in the introduction, really, and with Henry and Mike maybe on as well now, this is a trip down memory lane. 1989, rotational atherectomy was introduced, and it stayed in the exact same technology form until 2019, when the new device came along. And this, as I just heard, is still in use as it was in our center until weeks ago, really. 1989, that's when the wall came down. 1989, I looked it up, the Game Boy was brought to market by Nintendo. So that's a long while away. The catheter components and size, all of it is still the same. So this is this holds true. We've got a diamond coated burr at the tip, no coating on the other side. We got a drive shaft and a sheath, and we have a specially made guide wire, the Rota wire. And you have to know your sizes. There's a size charge, of course. The 2.0 burr, for example, will require an 8 French sheath. The 2.5, if you dare, a 10 French sheath. This looks complicated, but in essence, there are 3 little tubes that come out. one for the pressurized air, one electrical for the tachometer, and one drip to keep the whole thing dripping in fluid. You've got a console, which is now probably obsolete, but it had a lot of interesting buttons and old style meters to show what the pressure is like. And here we had the RPM signal. And of course, you still need air supply set up because it's driven by pressurized air. And this again is still relevant. It has to go at the end of the wire when you use Dynaglide. Will dearly miss because it gets you into imbalance if you try to do rotablation by pressing on this pedal and screen at the same time. So you have to lift both feet and alternate. You can get quite imbalanced. So that's now obsolete as well. We have it all at a fingertip. So this is 2019, 30 years later, the new Rota Pro came out. Now, the principle of operation, and that's why I can keep my old slides, is still the same. It's differential cutting. All diseased plaque is inelastic. High-speed rotational ablation differentiates healthy elastic vessel wall from inelastic plaque, and it preferentially cuts all types of inelastic plaque morphology. And that's where the egg comes in. I don't know if you remember, Henry, Mike, in the 90s when we went to the meetings and they were demonstrating the differential cutting of rotablation, they had hard-boiled eggs there. And they would use the rotablator to show that you can drill into the calcium of the eggshell without any problem. It went through like nothing. But once it touched the elastic inner layers, there was no harm to the tissue. This was always unharmed. So that's the differential cutting idea. And remember the eggshells. So elastic, no effect, inelastic. The diamond crystal will cut into it and will just rotablate it out of the way, pulverize it. So that sounds like a dangerous tool, and in the wrong hands, I still believe it is. There are complications compared to PCI. No flow or slow flow. It's bad if you have it in the last remaining artery, for example. 3 times more events if you do rotablation compared to normal angioplasty. Perforation, a 4 times increased risk. Vasospasm, 9 times. For bird jamming, there are no data, but it is an acknowledged and actually feared complication, as we will see. How can you make it safe? I think it's all about strategy and knowing what you're doing. Use the Rota floppy wire. Speed 150 to 170 K. You have to have a drip of saline, heparin nitrate, verapamil. There used to be a specific solution sold with the rotablator, but that has come off market. I forgot why. We stopped using pacing wires for the right coronary artery. There is a risk, however, of complete heart block due to embolized particles. And you have to use the packing technique. I will show that in a moment. Limit the ablation to 15 to 30 seconds at a time. And don't use a burr that is as large in diameter as your vessel. That will get you into trouble. Avoid wire loops, of course, bends, but that's easier said than done. I've only recently ended up with a little loop in the ascending aorta, operating with a second operator that I hadn't done that before with. So it's very, these wires are very flimsy and very difficult to operate at the beginning. An extra slide for the prevention of slow flow, because it is preventable. Be careful with your burr size. Gentle advancement and intermittent retraction is this pecking thing. And each drop in RPM of more than 5,000, you stop and come back. Less generation of heat with that management. And if you re-establish flow, of course, you can clear the vessel and the downstream area of particles. So, and if things happen whilst you ablate, then increase the time between the ablations so that the tissue can recover. Right, you set up the system. This is a newer slide, and you think about draw, drip, saline drip from bottom of the advanced catheter, rotate, just let it spin once, but don't let it spin. Don't let the burr come in touch with the tissue that you have on the table, because it'll go into it. And move the advancer and make sure the wire is visible. And there is a break in the system now, automatic. Make sure it is functioning. And then this is a bit of an old slide, but still working, showing the pecking. We're after this heavily calcified short lesion in the right coronary artery. And we've done this recorded. You can see me here moving the advancer slowly. This is the response on the right hand. You go in, you wait a little bit until the RPMs decelerate, and then you come back, and now we've pushed through, and we've done already our job here. And now we parked the rotablation burr in a safe position where there is no stenosis. It's important to listen, but of course now the console makes it easier for us to recognize when the burr grips and there is a reduction of RPM. So you get a hollow triangle if there is up to minus 5,000 RPM, no more than 5,000 RPM. You get a full triangle, yellow, if the deceleration is more than 10,000 RPM. So the burr has got resistance and can't fully turn at 164, which is the target and recommended at the moment. And you get this. And that is bad, because if the burr stalls, then you have the rotablator stuck in your lesion mostly. Now the jammed burr can happen in two ways. The first way is you have an entrapment, and that is you go through forcefully, and that is very frequently a beginner's mistake. You push and push and push, and then the rotor popped through, but it hasn't ablated. It has just edged its way in. And then you get the Caucasi effect. Now you wonder what that is. Well, it's named after Japanese Caucasi dolls. A feature of these dolls is their head is bigger than their body in diameter. And this is exactly where you are at the moment. You're stuck with a burr distal to a stenosis, but you can't rotablate your way out because on the back of the tip, there is no diamonds. It's only front going. So that's a bad situation. Burr entrapment can happen in another way. You can stall in the lesion. There's no name for this. You're just stuck. And there's a lot of literature about how to get out of trouble, and there is a lot of literature about the rotablation experience. Here is just one example. Exactly that happened. Caucasi, the burr is behind the lesion and can't get out. So what you have to do is first pull. If that doesn't work, you have to get past the burr and dilate it free. That is often not so easy because you've got a rotablator in with a shaft in the guide catheter, and there's often not enough space. So sometimes you have to use a second guide catheter to achieve that, and eventually get the burr out with pulling. And sometimes if even that isn't possible, you can cut your rotablator, take out the drive shaft, and that leaves you with enough space to put a heart rail catheter, a guide liner over it, and then have maximum pulling force at the lesion to get the lesion out. There's even an algorithm for what you can do in these situations. And sadly, if you look at the right bottom side, it ends with surgical removal. And here is such one such case. Of course, that's highly embarrassing, but if all else fails, then it's better to call the surgeons than pull out the full artery. Now, how about perforation? If there is selective ablation of calcium, that shouldn't happen. But I think you can really make it happen. In severe calcification, we've all seen it. If the vessel is severely angulated, tortuous, and if you use big burrs in CTOs when there is, dense calcium everywhere and deep calcium, you can make the egg break. Just an illustration of what happens with wire bias. The rotational atherectomy can just push into tissue in a situation like that. Of course, what you do is you relax the wire, pull back the tip, align the guide, undersize, and start with pecking again instead of going into the tissue with force. So conclusion for rotational atherectomy really is it requires careful technique. It requires attention to detail, and an unrushed approach with precaution is the best way to avoid complication and the embarrassment of asking a surgeon to retrieve your diamonds. There's interesting reading. I put that up because Emanuele is the first author. He was here at the CAF conference 2 weeks ago, I think. And he's still interested in the field. And I think there is a new group in Europe, C4, Flavio Ribicini is heading them at the moment. So there is considerable interest in treatment of calcium, rotablation, and the new technologies. We will hear more, and I think they are working on a new expert consensus, so we'll have an update of this old document fairly soon. Right, this is the intermission sign. We now swap and do something completely different, but it's the same topic. It's still calcified lesions. It's the Shockwave that has come in as new technology for you in Europe. We've been privileged to have it for the last 5 years already. Although, as we had the entry discussion, it wasn't commissioned in England, and hence we had limited use of it. What is it? Well, it creates sonic pressure waves inside a balloon catheter. From a mechanism, it's the same as the laser would do, an excimer laser at least. That was my field of research 30 years ago, showing that the firing of an excimer laser in whole blood creates massive pressure waves, pretty much like this. The benefit here of this device, of course, is it is a balloon, and hence inside there is fluid, and these pressure waves can be directed. They can travel into the wall of the artery. This is the 21st century equivalent of the eggshell test. this is what they do now. On the left-hand side, you see IVL catheter, and this is just little pieces of stone, concrete, ceramics. And you're supposed to play here. No, I don't know why that's not playing now. I really want you to see this. It was perfectly all right to start with. There we go. And if you hold your finger with your soft tissue, it just gives a little irritation, no damage. So the same principle of selectively addressing the calcium, and of course now in the vessel. The system is very simple. It's got a compact console that is rechargeable, and you know, all you have to do is use this part of the device, connect it in. Of course, it's draped inside a plastic housing, and then you have a balloon catheter. And what you have to do is connect, insert the balloon, inflate to 4 atmospheres, and then apply energy 1 per second for 10. And it comes with a limit of 80 pulses per balloon. So you can do that 8 times 10. And then we used to say, ignore shock topics. You know what shock topics are? So these are the ventricular extra beats that are caused by the lithotripsy pulse, LPVE, LP, lithotripsy pulse induced ventricular ectopics. And you can see them in various degrees. Not all patients get them. It's a simple mechanical irritation or mechanical induction of a depolarization in the myocardium, probably similar to poking it with the picto catheter. So I thought we simply ignore them until I saw this case report in preparation of this talk. So there is indeed one case report where, and they've got a fantastic video of it, where these ectopics led to ventricular fibrillation in a patient, 79-year-old lady. They had a look at it with electrophysiologists. They couldn't find any particular susceptibility in that patient, so we leave it at one reported case. Nothing, of course, happened to the patient. She was defibrillated like you do in the cath lab with no sequelae. But we have one case out there, and we'll come back to this issue when we review the data. Usually what you see is when you place this balloon and you start to inflate, start to treat, sorry, you have it at 4 atmospheres. This is still at 4 atmospheres, and you can see how this balloon slowly gets bigger and the indentation goes away. It's a slowish process, not a pop usually. And then you can finish your angioplasty. Some of these slides I borrowed from Jonathan Hill, who is an expert in this technology and has been driving it in the UK for a long time now. So what are the data to support the use of Shockwave? If you think about it, it's very difficult. What is there to prove? If you use cases that are incredibly difficult, then you can only compare it maybe to the rotablator. But then our indication for use would be difficult, as we can discuss at the end, because I use the rotablator in circumferential calcium where I might not even get my balloon in, whereas the rotablator would be useless in not circumferential calcium in bigger arteries. It's very difficult to really make a case for make data for the usage. So what they've done is in 3 sequential trials, they just showed that it's safe and it works when there is calcium. And the Disrupt 1 was 60 patients, and from the beginning there was input from Yale. Professor Lansky was involved in the study. Same at Disrupt 2, a larger series, more countries, and now recently Disrupt 3 was presented by Dean Kyriakis and then published by Hill and the group in JACC. 431 patients with an OCT sub-study that showed the mechanism of the Shockwave. The main findings, it's effective. The effectiveness criteria was primary endpoint was less than 50% residual stenosis after stenting in a population with 100% severe calcification. And I think, Steve, I saw Yale was contributing a case. We did, I think, 5 or 6. It was very, very difficult to get patients that fulfilled the upfront criteria. You had to have 2 lines of calcium in the target lesion, and of course it was all elective. But they managed to do the study. Now, how about safety? I think that's the main feature of this study. There were only 2 serious final angiographic complications. You know, of course, the anxiety is that this will cause massive dissections. Well, it didn't, at least nothing that couldn't be fixed with a stent. There was one perforation with one, which wasn't a free perforation. It was one of these severe dissections with extravasation that was treated with another stent, I think. So MACE rate, as expected, they went for performance goals and compared it to the orbital trial, and we're very happy with the results. And I think that's good. There is no way you can compare it with something else. The ECG sub-study, you have to dive into the online tables, and I just want to point out there was no arrhythmia in the capture group, and the majority of patients, or 2/3, had no IVL-induced capture, which is their word for the ventricular ectopics. So at the end, I just want to show you what changed the mind of a lot of people and what is probably the best way of showing how important this technology is and how relevant. It's one case that changed or convinced a nation. It was a live case at ACI 2020. I wasn't present, but I heard about it immediately. It was the planned treatment of an underexpanded stent in the right coronary artery, this one here. Initially planned for a rotablation, so rotablation of an underexpanded stent as a live case. They did that at the Golden Jubilee in Glasgow. This is the situation. This is the underexpanded stent. There was a gap. They had to stent a dissection after high pressure inflation and dissection here. So a really messy situation. They did an OCT and showed almost circumferential calcium. And the pullback, you can see this underexpansion here at this part of the stent. This is dreadful. They tried to predilate again with a 3.5 NC balloon, but there was no movement there. So this is now live. I just put this little sequence out of their promotional video, but this is the original situation. Immediately after one application, there was improvement. After 3 applications, they saw this. That's when apparently the audience gave a big ah or sigh, because it just was so easy. So this is evidence, and then there is one case, and this is a case that would otherwise either be undoable or be doable with a complicated rotablation of a stent into calcified vessel. None of it is according to the IFU. It's all a very difficult terrain, but the Shockwave application was safe and quick and led to an amazing result. Final 2 slides, role of imaging, assessment of calcium, yes, extent and depth, length and arc. Gary Mintz has shown us with IVUS, and now they're doing that with the OCT as well. Again, a slide from Jonathan Hill, who favors the assessment of calcium, and then according to an algorithm suggests that modification is required. Margaret McEntigard from Glasgow promotes this algorithm, which is difficult to read, but basically it leads to all these different modalities that we have now talked about, apart from laser, with a rotablation and shockwave at the center of the final strategy. So how about our case then? We're still waiting for TAVI, and we're in this situation. And until recently, Steve, we would have done exactly the same thing. We would have brought out the 8 French and the rotablation kit, and maybe changed the operators in some cases, and then had gone on with rotablation and rescheduled the TAVI. In this case, I've done that with Mick Oskor. We brought out the IVL balloon, and this was after 10 seconds. This was after 40 seconds, 40 pulses. This was the result after IVL. This after stenting, and this after TAVI. It's just too easy. So in summary, calcific coronary artery stenosis are a major obstacle to good PCI outcomes. Strategies to overcome the problems include imaging and extensive lesion preparation. Rotational atherectomy and lithotripsy are essential tools. And then finally, Steve, I was looking for a funny quote, something like along the line, if it's hard, be smart. And the best I could find was from your part, from your side of the Atlantic. Life is hard if it's harder if you're stupid. Smart. Okay.
Well, we all have something
Any
to learn.
questions?
Yeah, I have a ton of questions. Sorry to dive in. That was great. You know, I had told you at the beginning, before your talk, we were chatting, and we've used the below the knee peripheral lithotripsy in coronaries because we don't yet have access to the coronary balloon.
Yeah.
And it's quite a challenge to cross the lesions with that big long balloon. How have you found the ability to deliver the coronary lithotripsy balloon?
Well, I've got, as I said, limited experience, a dozen or more, but I've used it in the situation. It's funny. I've used it in the situation where you can't inflate a balloon, as a bailout. And by definition, a balloon was stuck in there, usually an NC balloon. And in that situation, you get that balloon in as well. In one case, we used a guideliner to give us a bit more room. But I'm sure there are situations where we can't even get a balloon in, where we then swap over, and that's where the rotablator is still absolutely needed.
Yeah, I think both, sounds like both are going to be pretty specific devices. Rota will still have its place, of course.
Steve,
yeah.
So we've had using there's a few things that are different about the United States than Europe that the fellow should consider. One is, if you have sequential lesions and you're using the approved coronary balloon, the billing for this in the United States is as a balloon angioplasty. So the cost of this device is not inconsiderable. So you have to take that into account when selecting your product. The second thing is, we've done we did them together, 2 in-stent restenoses that wouldn't inflate, and we used the Shockwave below the knee, and we had 2 balloon ruptures at 4 atmospheres. And I'm not sure what that's from. It could have been a strut.
What did you do then? An OPN balloon? Do you have OPN balloons?
We went back down with the Medtronic balloon, and we can take that to 30 atmospheres, and it opened. They both opened, but it's just something to I haven't seen it reported, but I think it's just something worth mentioning. And unless they think, I don't think this is going to be quite as popular as people think it's going to be in the United States, unless there's a change in the DRG.
Well, I'm not sure. I can't see it as being a popular device. For me, it's a device that helps me in situations that would otherwise be very difficult. So I'm a niche user. If I can't really blow up a balloon, and it's rotablation or that, or there are even cases now where I've seen good results after rotablation and then still under expansion. Or of course, if the stent is in and is under expanded, and you can't for the life of you not get it up even with maybe an OPN balloon, which is rare. But I'd prefer that to an OPN balloon at 50 atmospheres. So, but I don't see it used as we did it in Cat 3, where whenever there is calcium, you use it up front.
The other thing, have they done studies with the longer balloons, the below the knee balloons, where you had tandem lesions, and they used it to pulse both tandem lesions with relatively normal tissue in between? And if so, what happened to the normal tissue?
I'm not aware of that. I think the idea is generally that normal tissue is not affected, and you wouldn't think it would be. But of course, I had that discussion with Anthony recently. Of course, we don't know about the long-term effects. I wouldn't expect anything drastic as we've seen with radiation, these late candy wrapper restenosis effects that came up after a lot of cases were done. Because of the mechanism, it's just sound that travels through. But of course, we'll only know once we have long-term follow-up of in the first 6 months, that nothing seems to happen.
Andreas, can you just speak to your experience about using laser for expanded stents, because that has been our go-to. We have a lot of
I have
patients.
zero. We've got an enthusiastic colleague, Elliot Smith. He will talk about CTOs in this cath conference soon. So you'll ask him. He's done a couple.
Okay, very good. Any
but generally, as from my research way back when we detected the shock pulses, you would expect that the direction of laser into red blood and the firing at the site of the restenosis would generate localized pressure similar to this. And if you're lucky, you might rattle up some calcium there. But you don't get a side effect. You don't get an effect lateral to the tip because it's all forward looking with the laser.
Andreas, I can talk a bit about our laser experience at Bart, if you wish.
Yes, of course.
And so this is more as a clinical director's type hat than the interventionist that's doing it. I mean, clearly it's an interesting technology, but it's interesting. It's never really flourished in the UK system apart from the odd centre. And that's partly based on cost. And then the big bit here is what it is we're trying to achieve. And I've seen the messaging about how much the devices cost. And clearly, you know, some of the issues here are that a technology that's easy to use but very expensive has a big danger of being used too much and costing an awful lot. And so I think it's always worth reflecting on what it is you're trying to achieve in the individual cases that you're doing. So laser was expensive. It has a piece of kit that obviously needs specialized training, and it's probably, you know, worth doing if you can afford it and you do it in volume. But I think our understanding or our usage of it was so low volume, it rapidly fell off the agenda. The few cases that we did use it in, and that was sort of proctored, and then we did a few ourselves, were reasonably successful as a sort of debulking tool, obviously avoiding calcium, but more about soft tissue. But as I said, I haven't really, as the clinical director, been approached to make the case that we need it. So I would argue that in our experience, we need it so infrequently that you've got issues not only around cost, but around skill base.
Yeah, I was speaking to our experience because we have a brachytherapy program here, and the patients that are referred for brachytherapy, at least half of them have really underexpanded stents, and some of them have had multiple procedures and even second stents in the underexpanded segment. And so those are really hard to dilate. And without lithotripsy, our go-to in those really refractory underexpanded lesions that have been stented previously has been laser to generate those shock waves and then try to soften the calcium behind the stents. And, you know, we've had pretty good success using that as a last stopgap. We've probably done 10 cases in the last year that were really refractory and had some success with laser. So I just, practically speaking, I agree, it's a very expensive, but again, very specific indications in the current era.
I think there was a question in the chat, I just looked it up, about aortoosteals, right RCA aortoosteal, and one answer was it was excluded from the Shockwave, but I think that's a good location for rotablation usually.
So Andreas, that was a great talk, except I want to say there's one complication you didn't include, and that's, maybe it's just unique to me because I'm a bad operator with roto, but I've cut the wire a few times and left the wire hanging in the coronary. So one notable case Rob and I did together, and then a couple of other cases over 20 years.
I've heard it as well. I've not. I managed to avoid that one, although everything else has happened to me, but I haven't done one.
You're a better man than I, because I've done it. I've failed to learn from my bad experiences.
So that's usually when a loop happens, and you can't see the loop because of a bad eyes or just bad X-ray, or it's just in the wrong place, and you then start rotating, right? That's what.
Yes, well, that was one, but the other two were both really sharp turns, highly angulated. One was an osteal right, one was an osteal circ, and I was not patient enough. And so just to point out to the uninitiated that wire is so fragile that if you don't have it lined up, then the roto burr can cut right through the wire.
Steve, can I ask, because we have had...
Coaxial. That speaks to how important with the rotablator, if you're doing an osteal lesion, that the guide needs to really be coaxial. If you're not coaxial, that's exactly what can happen, and as well as perforations and dissections.
Yeah.
So Steve, sorry, I was going to say, so thank you for confessing. In my time at Bart's and before at London Chest, we've had 3 sheared tips. And when we spoke to our UK lead, Adam de Belder, about it, he said, oh, it doesn't happen. So first off, thanks for sharing. It sounds like we've got a case report coming up and that we can share experience. But I was going to ask how you dealt with it, because the 3 that I was aware of and we had to obviously investigate, and one of them led to quite a nasty legal situation, was the transition, which is probably useful for your fellows to also be aware of. And that we thought the mechanism of failure wasn't sharp angles or loops, which are all possibilities, but what happened was the wire was coming back. So you'd have a combination of the burr jamming, the guide cath moving and pulling the wire back. And as you know, the soft tip of the rotor wire is soldered onto the stainless steel shaft. And apparently that's the site that shears off when these things happened. So basically all 3 of the cases that I've investigated were sheared tips because the wire moved back and people didn't pay attention to keeping the burr away from the transition. Did you guys remove the wire, or did you leave your wires in?
Yeah, so unfortunately, none of my experience was that, just the tip. I was trying to go around sharp corners in all 3 of mine and cut the wire in the shaft of the wire. So we had a segment of wire plus the tip. And in all 3 cases, we were fortunate enough to put another wire down and then stent the vessel, trapping the wire piece behind the stent. And so as far as I know, one case I've definitely repeated the angiogram for other indications about 2 years on, and the wire is still there behind the stent, and but it's the artery is open. So I've been lucky to kind of get out of that. But in all 3 cases, it was not the tip; it was mid shaft, just trying to be too aggressive going around a corner.
A lot of things can happen with the rotablator. It's always good for a case report.
Yeah, a lot of bad things to experience, but I think I agree with you. It really takes caution and patience and a lot of experience to do it well and to stay out of trouble.
This is Chris. Thanks for the talk. Really good. It seems that this device has a lot of advantages in terms of lower risk and ease of use. So it would be natural to go to it as the go-to technology when you can't dilate. How many times have you gone to the Shockwave device, but then had to then go to rotablator because it didn't get the job done?
I'm not a super user of this device, so I think I'm the wrong person to give you big numbers. I know there are some cases. There is research about what happens if it's not concentric. You should only use it if there is concentric calcium because of the travel of the pulses. And there have been descriptions of bulky lesions, eccentric, that didn't go away, which you can imagine can happen. and there was a rotablation afterwards. There is a trend in the community of the calcium enthusiasts, I may say, to try out whether the combination should be used in any case, which of course is counter our financial interests, but might be interesting in terms of results. Now, invariably there will be a case in all my cases where I couldn't dilate and was sure it was calcium. This device worked, and I had a good result with the stent afterwards. And I think that's the experience of most people.
So Andreas, I just want to say thanks again for starting us off here. I think this collaboration is great. I'm glad Anthony was on as well. I think, you know, you guys, your expertise and your experience is going to contribute much to our conference. So I look forward to the lectures from Bart's in the future and hope you guys can jump on these calls even when you're not speaking. Thank you very much.
Absolute pleasure. It was fun.
All right,
Okay.
great.
Bye,
Thanks.
guys.
Bye-bye.